Good morning, Chairman.
Good morning, Trina, and welcome to everyone participating in and listening to this meeting. I now ask Trina Cope to confirm the attendance of committee members, please.
Thank you, Chairman. So prior to the start of the meeting, if I could please ask members to confirm your presence when your name is called. Councillor Carl Macy.
Present.
Councillor Chris Brewis.
Present.
Councillor Susanna Barker-Milan.
Present.
Councillor Bill Bilton.
Present.
Councillor Matthew Fido.
Present.
Councillor Mrs Sandra Harrison.
Present.
Councillor Rob Kendrick.
Present.
Councillor Colin Matthews.
Present.
Councillor Robin Renshaw.
Present.
Councillor Glynis Scalesi.
Present.
Councillor Angela White.
Present.
Councillor Mark Whittington.
Present.
Councillor Stephen Woodliff.
Present.
Councillor Linda Wotton.
Present.
Thank you. Councillor Ray Wotton.
Present.
And Dr Brian Wookey.
Present.
Thank you, Chairman.
Thank you. Before continuing, I would like to once again welcome everyone who is in this appointment and listening online to this meeting of the Health Scrutiny Committee. We already have confirmed which committee members are present, and we also have present Councillor Mike Thompson, Executive Support Councillor for NHS Liaison and Community Engagement, and Dr Cowley Chowdhury, Public Health Consultant for Lincolnshire County Council. Other participants will be introduced when we reach their item. I would like to ask members of the committee and other participants to type speak in the chat function when you wish to ask a question or make a contribution. Also, please turn off your camera and microphone when not participating. Please keep your questions and contributions succinct and concise, ideally no more than 2 questions per item. And I would also like to stress the importance of treating all our contributors today with respect and to bear in mind our role as constructive scrutineers. I'd now like to move into agenda item 1, apologies for absence and replacement members, please, Trina.
Thank you, Chairman. Yes, we've received apologies from Councillor Rosemary Cabery-Brown, and we have Councillor Linda Wotton as her replacement here today. We've also received an apology for absence from Councillor Sue Woolley, Executive Councillor for NHS Liaison and Community Engagement. Thank you, Chairman.
Thank you, Trina, and welcome to Councillor Linda Wotton. It's a pleasure to have you with us again. We'll move into agenda item 2, declaration of members' interests. Do members have any interest to declare, please? No? Okay, thank you. If anything comes up over the time of the meeting, then please just type in the speak box and we will ensure that that is recorded down for you. I'd now like to move into agenda item 3, the minutes from the 16th of December 2020. I'd like to confirm the minutes from that particular date, which are found on pages 3 to 9 of the agenda pack as a correct record. I plan on taking these on block, so can I ask for a proposer, please?
Happy to propose them, Chairman.
Thank you, Councillor Brewis. Do I have a seconder, please?
Chairman, happy to second.
Thank you, Councillor Wootton. In which case, we need to take a roll call for this, so I'll hand over to Trina, please, once again for the roll call.
Thank you, Chairman. Can members please indicate whether you are for, against or abstain when your name is called? Councillor Carl Macy.
For.
Councillor Chris Brewis.
For.
Susanna Barker-Milan.
Abstaining.
Councillor Bill Bilton.
For.
Councillor Matthew Fido. I'll come back to Matthew. Councillor Mrs Sandra Harrison.
For.
Councillor Rob Kendrick.
For.
And Colin Matthews.
For.
Councillor Robin Renshaw.
For.
Councillor Glynis Scalesi.
For.
Thank you. Councillor Angela White,
4.
Councillor Mark Whittington,
4.
Councillor Stephen Woodliffe, Councillor Woodliffe,
4.
thank you. Councillor Linda Wootton,
As
And
I
council-
wasn't, as I wasn't at the last meeting, I have to abstain. Thank you.
thank you, Councillor Wootton. Councillor Ray Wootton.
4.
Can I just go back to Councillor Matthew Fido, please?
4. Sorry, sorry.
That's okay, thank you. So that's carried then, Chairman.
Thank you. I'll just confirm the minutes of the last meeting are confirmed. In which case I'd like to move to agenda item 4, the chairman's announcements. My announcements have been circulated with the agenda, and my supplementary announcements were circulated on the 18th of January and subsequently on the 19th. I would like to propose A, to note the chairman's announcements and supplementary announcements, and also that I, as chairman, write to the Right Honourable Matt Hancock MP, the Secretary of State for Health and Social Care, to request for the local NHS to be allowed to share local information on the rate of vaccinations being achieved. Do I have a seconder for my proposal, please?
I strongly support that, Chairman, and thank you for your notes and information you send us, which I find very useful. Thank you, Chairman.
In which case, I would like to go to the vote, please. So all those in favour, can you please show? Thank you.
That's carried then, Chairman.
Thank you, Trina. In which case, I would now like to move over to agenda item 5, the Lincolnshire Community Health Services NHS Trust COVID-19 update. This is found at pages 19 to 61 of the agenda pack, and I would like to welcome our presenter from LCHS, Tracy Pilcher, Deputy Chief Executive and Director of Nursing for Allied Health Professionals and Operations. Before I bring in our speaker, if anyone wishes to speak or ask questions, can you please type speak in the box. All questions will come at the end of the presentation. Tracy, if I can hand over to you for about 15 minutes just to run through it, please. Thank you.
Okay, good morning, Chair, and thank you for inviting us this morning to give you an update on LCHS and our COVID-19 response. So from a LCHS perspective, obviously we've moved back into our level 4 national emergency along with the other NHS provider organisations across Lincolnshire, and working in a very coordinated approach across Lincolnshire to support patients in terms of both their acute and then community care. We have focused quite a lot on ensuring that we've got the right structures in place and also learned lessons from our first COVID response and first wave. We have got further updates since this paper was prepared, because obviously the fast nature and fast pace, some of the issues around the vaccination programme and the rollout has accelerated beyond what's in this paper, but this was accurate at the time that it was put to our board. We have started asymptomatic testing for staff using lateral flow technology, and at the moment we have approximately 20 staff that are self-isolating at home with COVID or COVID related symptoms, and our overall sickness level remains about 6%. Our lateral flow positivity rate is less than 1% though, and again I think that's indicative of a good response in relation to that. From an operational perspective, we've used very much similar integrated urgent care has been quite significant in supporting patients at home. So they can access the service through our clinical assessment service. We have our UTCs in operation, but we've also focused quite a lot on ensuring that we're managing patients in the most appropriate settings. So we've introduced and accelerated the focus on EMAS crews on scene, and this is where crews on scene with patients can phone through to our clinical assessment service, and we can look through alternative pathways, so either additional support that could be put in to maintain that patient at home, or whether they can do a direct admission into a community hospital. Real focus on trying to keep patients at home and avoid taking them to the acute provider unless absolutely necessary. And we've got figures in there in terms of the impact that that has had. But you can see quite a significant impact in terms of the ambulance conveyance rates of December 2020 versus December 2019. But it's something we monitor every day. We work very closely with the acute providers to make sure that we're working collaboratively and supporting patients at home. The Grantham UTC continues to be in place, and this is a 24/7 walk-in urgent treatment centre that was put in place in Grantham to support the green site, but also to ensure that we managed as many patients, again, within that local environment and local population as possible. We have got, again, information in the pack and the paper around the numbers of patients, but consistently activity at Grantham UTC has remained fairly stable since the beginning of the UTC offer. And again, we monitor this and report this on a daily as well as weekly and then monthly basis. Our other UTCs at Pilgrim and Lincoln are 24/7 walk-in, co-located with the ED service. We also have the restoration of the UTC in Gainsborough. So as you'll remember from our last paper, we have some temporary changes to our MIUs, and as we've restored them as UTC so they're able to meet the same standard and standardised approach across Lincolnshire. And again, we've got some information around our UTCs and their primary activity levels. We're working all the time to look at different ways that we can support both the community but also primary care. And one of the areas that we're focused on to support primary care is the same day urgent primary care. So we're doing a pilot in the Skegness area where we can support those primary care practices to move some of that urgent primary care on the day appointments into our UTCs or co-located at Skegness Hospital. And there's a lot of work going on around Skegness, making sure that the environment of care and the support that we're providing to that local population is in place. We're also working and leading what we describe as the patient flow cell. So this is part of our COVID response. And again, in that, it's a coordination of the NHS providers, social care, local authority, as well as St Barnabas and primary care about, and ensuring that we're looking after patients across the system and we're managing some of those flows of patients. Again, very much focused on trying to support patients at home or as near to home as possible. There's been a lot of work going on in relation to palliative and end-of-life care services, and in the report also we've been able to restore Butterfly Hospice, and that opened again on the 4th of January, and since it's been open, primarily we've had all of those 6 beds full, and again we're monitoring the capacity in Butterfly Hospital and supporting kind of that ongoing development of palliative and end-of-life care services. Community hospitals, we've been working across community hospitals. We have 2 wards that we've designated as COVID positive wards, one at Louth and one at Skegness, and alongside other organisations working to manage patients, and that kind of IPC focus very much on supporting patients in care as close to home as possible, but also making sure that we're moving patients out of the acute at their first possible opportunity, working very closely with the local authority around whether those patients move into our community hospitals or into a care home setting. The other area that we've really focused on is the hospital discharge service, and again working very closely across organisations to make sure that we are identifying different pathways. There are 3 pathways of care for patients on discharge from hospital where we have an agency involved. So pathway 1, which is care at home, and that can either be under the local authority, LCHS or voluntary sector. Pathway 2, which is going into community hospitals with what we describe as bedded rehabilitation services. And pathway 3 is where a patient needs to go into a long-term care placement. And again, as you are aware, with the designated settings. So these are in settings where care homes have gone through additional IPC support to ensure that they have the right IPC staff training and environment to care for COVID positive patients. And again, we monitor those COVID positive pathways very closely, making sure that we are supporting patients in the right place and the right setting for their care. And that's primarily the first kind of report. We've also included in the information the work that we've done around our UTCs. I think we spoke about it at the last meeting in terms of the 2 UTCs at Skegness and Louth, which we've made temporary changes to support our COVID response. So they are now open to walk in from 8 till 10 o'clock at night, and then out of hours are supported through our clinical assessment service and also our home visiting service. And last time we sent some additional information so you could see where those home visiting teams were visiting to and the activity in both of those settings. Our engagement with the population or looked at extending that. So initially when we made those temporary changes, we'd made it as part of the COVID first surge or first wave. As we were going into second wave at the beginning of November, we'd gone out to engage with the public about extending those temporary arrangements to the end of March. The public, as you can see from the response, we had a good response to the survey. The public identified that they understood why we'd made those changes, but there were some concerns raised around how those changes were initially communicated and the numbers of stakeholders that were involved in part of those changes. And also, I think there was an underpinning concern that those temporary changes might be made permanent without the right level of engagement and consultation. And again, we've kind of reassured and given assurance to the Health Scrutiny Committee that they are temporary changes and they are part of a COVID response. They're not part of our long-term strategy for those 2 services. If there are any changes to long-term strategy, it will be led through a proper consultation and engagement being led by the CCG and the commissioners of those services. Thank you, Chairman.
Thank you, Tracy. Okay, I'd like to hand over now to our questions. I've got 4 speakers so far, and I'd like to start with Councillor Chris Brewers, please.
Thank you, Chairman, and I think I'd like to try and thank Tracy once again. It's probably not her particular purview, but certainly the concern at my end of the county is that the key to this whole thing, particularly in view of the news last night, is to get people vaccinated. And at my end of the county, people have been asked to go to Norwich and Bedford. And if you were a vulnerable person who had to go to Bedford, it's probably nearly a 10-hour round trip by public transport. And I just want to know that what is happening at the moment is causing a huge disincentive to people to get vaccinated because of them having to spend virtually a whole day getting there and back. And when do you have any idea when vaccinations will be offered at local medical centres? Because at the moment we're not going to catch people because people are going to refuse to go out for a whole day to a distant place when they have no transport of their own. And even if you're going to be inoculated, it's inadvisable to drive on your own anyway. So I don't know whether you know anything about the problem we're now having of people actually wanting to be vaccinated but refusing it because of the logistics of having to go huge distance. I mean, even Boston is 26 miles from where we are, which is an enormous distance. And if someone would have to do it by bus, it's virtually a 5-hour round trip.
Okay.
So it needs to be more local.
Chairman, do you want me to answer each question at a time?
That would be the best bet, please. Thank you.
Okay, so in terms of the vaccination strategy across Lincolnshire, we have a number of different areas that we're focused on. So there, as you know, there's 2 hospital hubs, that's at Lincoln and Boston, and they were just looking at further hospital hubs rollout across Lincolnshire. We have 13 PCN sites across Lincolnshire and 2 vaccination centres. And I think the issue around people, and we have had that feedback, the first vaccination centres, so these are the big centres where we'll be offering over 80s and the first 4 priority groups access into those vaccinations. Boston went live at the Princess Royal Stadium on Monday, and that is provided by LCHS. So when I said fast paced and moving, obviously that's come on since this report was first written. So that went live on Monday. We're monitoring the vaccination numbers going into that site, and with the anticipation that we will be able to do about 1,500 vaccinations a day through the Princess Royal. So it's our biggest, what we call, vaccination centre. And then the different PCNs obviously will have a different level that they're able to offer parts of their population through those community hubs. And that all the time what they're looking to do is roll out further areas that they can provide those vaccinations closer and closer to home. So obviously, as you would appreciate, as the vaccination kind of programme first steps up, we're very much trying to put it in place very quickly. And then as the vaccinations, different vaccinations become available, they need different storage, different pharmacy support. So that's where we're rolling out and looking at the exactly point you've picked up, Councillor Bruce, about the ambition being that people will live within a 10-mile kind of distance, maximum of 10 miles from a vaccination kind of hub or centre. And we're just working that through across Lincolnshire now to say, OK, where have we got some hotspots, as you described, and then what's our solution? So how do we bring that in? Now, always within the vaccination strategy has been the idea that we'd have a roving model as well to supplement some of the large centres and some of those hub models. That clearly is being led by the CCG, and there's further work going on all the time to look at how do we exactly address your point. The issue about people going onto the national system is what they'll be offered at that stage is an appointment that's the kind of, I suppose, the quickest appointment for them. As we bring our vaccination centres online, as I say, what we've started with is lower numbers, because we have to establish what we describe as the pods, and then the activity and demand, with the idea that Princess Royal will be able to do up to 1,500 vaccinations a day, and that is running 7 days a week, 12 hours a day. We're not there yet. It will take us a couple of weeks to get up to those numbers. And then we've also got a site coming on board in Lincoln as well, so that'll be our second vaccination centre, as we describe it. And again, that won't have as many availability as Boston, but we'll be able to vaccinate up to 1,000 patients through that site as well. So within the next couple of weeks, our whole vaccination services across the county should be up and running, with an additional support from a roving vaccination.
Could I briefly come back, Chairman? It's just
You may indeed, Chris.
When you say within a fortnight you'll have the wider one, does that also include local medical centres? I mean, in South Holland, as a particular example, I would say the two remotest places are probably Crowland and the Long Sutton Bridge area. All right, we're only 8 miles from Wisbech, but the idea of people being offered one in Norwich when they've got to go through areas with much higher levels of infectivity across West and Mid Norfolk, the idea of going to Norwich, which is 54 miles away, or Bedford, which is much further and more difficult to get to, just seems to me it's almost someone in Whitehall has decided what a good idea it'd be to send people all over the country to get infected. It's bonkers. So I just hope that we're not going to start offering people places over vast distances, which they, when they're vulnerable, they won't be able to take. Which is my point.
I absolutely understand your concern, Councillor Bruce. I think it's the national booking system. As I say, when you go on to the national booking system, what it will do is offer you the first appointment. Clearly, as our vaccination centres come online, there'll be more local provision. The actual PCN and local roving sites, the CCGs are leading those areas of work. So whilst I understand that they are plans, I can't give you the full details, because actually that's not what LCHS is leading. We're leading the vaccination centres. That's what we'll have kind of details around. The other areas, I'm aware that there is work going on, but I won't be able to provide you with the details of that, I'm afraid.
Well, thank you very much. And I think, to give you an example, it would be easier from here to get to Newcastle on Tyne than Bedford.
Yeah.
Thank you.
Okay, thank you, Councillor Bruce.
Thank you.
We've now got Councillor Renshaw, please.
Thank you. Good morning, Tracy, and good morning, committee. What I've got to say is partially to cover the work in the next item, the public health report, but nevertheless it is cross-cutting, so I think it's relevant. If it's not, I'm sure the chairman will rule me out of order. There seems to be an information vacuum and this is on a national basis, and of course what happens nationally percolates through to the local scene. It took a long time for the NHS to allow the press into some hospitals, and the effect of that is reality is suppressed, and the NHS it appears to be behind a curtain, and the public become unaware of the problems, particularly of items like the staffing resource, because that's the staffing resource needed in COVID is disproportionate to normal nursing, as we on this committee are sure are fully aware. How many people it takes to turn a patient, and with the staff shortages, it has a regressive effect on the problems. What we're doing, we're ignoring reality of death. It's going to take longer to deal with, and if we ignore the rules, and that's where the public health message comes across. And I think the public are very grateful to all of the NHS, and I can't emphasise that enough. But public actions and the behaviour appears to end with their little clapping at once a week, and that really is not going to help us. So we're all in it together, and I think that the more openness, it's got to help the situation improve. Thank you.
Okay, thank you, Councillor Renshaw. Got Councillor Wotton next, please. Ray Wotton.
Thank you very much indeed, Chairman. Tracy, can I refer you to pages 26 and 27 of the report? And first thing I've got to say is the Urgent Treatment Centre in Grantham, looking on Facebook on the campaign groups, has received very favourable reports, and the service has been really great at this unit. But looking at the figures, you say that less than 5% are being referred to emergency departments, but surely that figure is false, because people are having to go to Lincoln anyway, and they know there's no A&E at Grantham, so they're going there. So that figure is a false figure if you think about the reality of statistics. And therefore, I would ask that more services should be at Grantham Hospital. That's why we are campaigning for a better service or a return to A&E at Grantham.
So, I mean, what we, as you'd appreciate with the information that we have, it is the patients that are being referred by us to an ED because we can't provide the care in that setting. So, unfortunately, we wouldn't be able to understand or count patients that make their own choice to go to an ED because they know what services are not there. I think, as you rightly identify, you know, the service itself, where people have access to it, they've really recommended the service and really appreciated those services. Clearly, in the longer term, the kind of focus for Grantham Hospital is about returning a greater range of services to that local population, and we're looking all the time about how do we provide those services back to that local population, or are there different services that we can provide in a different way. At the moment, as you know, the Green site is delivering essential cancer services to patients in Lincolnshire that they wouldn't be able to receive if that site hadn't been changed to become the Green site and the UTC developed in that way. Absolutely appreciate that causes further issues for the population of Grantham at times, but I think it's where we're trying to balance those different places that we can provide services to patients with the greater needs of some things like urgent cancer services that need to be provided in a safe environment for those patients.
If I could come back, Chairman, with
You may indeed.
Thank you. Tracy, you're talking about future work at the hospital, but this site is only you're there only temporarily. The Urgent Treatment Centre is a temporary unit, so we, the public, expect the A&E to return once this pandemic is over.
Yeah. And I think we're very clear on it, on the expectations, and I think we're very clear on, this is a temporary change as part of a COVID response. The site has temporarily moved into a green site, and when I say future restoration of services, there are services that we've put into the community. So one of the pieces of work in the paper was about discharge to assess, and we've worked very closely with the local neighbourhood team to ensure that we're repatriating and discharging patients home with services wrapped around them within their local community or within their home setting.
Okay, thank you, Chairman.
Thank you, Councillor Watson. I've now got Councillor Whittington, please.
Thank you, Mr. Chairman. Thank you, Tracy, for the update. I've got several questions. The first kind of picks up on what Councillor Wootton has just been saying. You mentioned in your presentation that Grantham UTC is a 24/7 walk-in. I'm still picking up reports that some patients have been requested to dial 111 first. Now, so there still does seem to be a bit of a disconnect locally between what people are being told and the reality of the fact that it's supposed to be 24/7. So I'd welcome a bit of clarity around that. My second question is regarding vaccinations and the vaccination of NHS staff. I was a little bit shocked to read in the papers over the weekend that a certain percentage of care home staff and care workers have refused to take the vaccine. And obviously they're putting not only themselves at risk, but also their sorts of people they look after. I'm just wondering what policy the NHS takes about staff vaccines and what we do regarding those members of staff who refuse to take the vaccine, because I think the view of a lot of us would be not only are they potentially endangering themselves, but they have a choice about whether or not they endanger themselves, but it's also the potential impact that may then have on their patients. And my third question is around, you were talking about the 3 discharge routes out of hospital into other settings. Now, I want to specifically refer to the discharge pathway, into care homes, because I know that a lot of care homes, when COVID was first around, undertook some very, very, very rigorous procedures to sort of lock themselves down to try and keep COVID out of their particular care home. And the thought that we may be discharging patients into care homes with COVID really just does cause me considerable alarm, because medical staff and nursing staff, infection control is a part of their training, and they get, I imagine, quite extensive training in that. They also probably have access to the better PPE that's out there. But care home staff, obviously, expecting them to kind of be trained up in sort of infection control at such a short notice gives me concern. Also, I know some care homes are struggling to receive PPE because when COVID gets into a care home, it just goes through the entire cohort of residents. The care home that my mother was in Grantham was infected by COVID in November, and my mother was got a positive COVID test on the 12th of November.
We seem to have lost Councillor Whittington for the time being. We'll come back to Councillor Whittington when he's able to log back on. So for the time being, I will move to Dr. Wookey, please.
Thank you, Chairman. You can hear me. I don't know whether you can see me, but
I can see you and hear you.
Yes. Oh, right, good. Yeah. Thank you. Just a question, really, following up from what was said about the centres at Louth and Skegness. Healthwatch have also had a communication from the Friends of the Johnson Hospital in Spalding, really uncertainty about their MIU, what is happening to it now and what is going to happen to it in the future, and whether in fact LCHS has discussed this with the CCG or is intending to do so. That's the first question. The second is a broader one on the county as a whole, but because we're getting feedback from people around the county about confusion as to where they should go when they have injuries, particularly injuries that are perceived not really bad enough for A&E, we are going to carry out a survey to try and find out, A, what is happening now and what people perceive is what they intend to do. There is a feeling that they're a bit stuck. People are not encouraged to go to A&E. If there isn't an MIU or a urgent care centre at night, they can't go to that. I'm not sure that the out of hours service is operating at all now. So there is a potential gap, and if we're not careful, people are going to end up at A&E uninvited when they don't really need to be there. So that's something we're going to do over the coming months, and that is really for your information, but I hope it may give some results that we can then feed back to the CCG and LCHS. Thank you.
Thank you, Dr. Wilkie. So if I do the UTC, so one of the reasons why we do encourage patients to use 111 is because they can then signpost them to the appropriate service, and they have a directory of service available to them that tells you exactly what services are available across the county, including UTCs. So we can book patients into UTCs and able to treat those. In relation to Johnson, obviously it was an MIU, so a minor injury unit, not a minor illness and injury unit, which UTCs can support. And what we have been working with the CCGs on is, as we restore Johnson UTC, which is our intention, and we are working to a plan so it will be reopened at the beginning of April. We're working through that plan in terms of the actual service, and working with the CCG so that when we do restore it, we'll be able to restore it as a UTC so that it's got the same standards as the rest of the county. So those are the two things. Obviously, we've got to finalise that with the CCG, and the CCG have got to finalise that in terms of their own, I suppose, reporting structures. So at the moment, we haven't gone out and actually set a definite date with the public, but that's certainly our plan at the moment, is to restore it in the beginning of April and as a UTC.
Thank you.
Thank you, Dr. Wilkie. Councillor Whittington, I'll bring you back in. I think Tracy's got the bulk of your questions. However, if you want to just quickly go back over them and finish where you were, really.
Thank you very much, Mr. Chair. My apologies. My internet here in Barrowby, it doesn't give any indication there's a problem, but it just kind of flickers and then drops out. But I'm not going to risk the camera this time. I was going on because just the first question was the 111 clarification. Yeah. Second question, NHS staff and being vaccinated. Third question was the care pathways back into care homes, because I know care homes have taken a lot of effort to keep COVID out of their nursing homes, but once it gets in, it spreads like crazy, because the care home my mother was in was infected by COVID early November, and my mother was diagnosed with a positive COVID test on the 12th of November. Quite a lot of the residents and staff came down with it. One member of staff unfortunately passed away. But after my mother was never seemed to really properly recover from it, and then subsequently developed chest infection and a leg infection, and she died on the 11th of January. Now, as somebody who's been affected by this, I wouldn't want COVID knowingly to be put into care homes. It's too late for my mother now, but there are thousands of other mothers across Lincolnshire in care homes, other people's mothers in care homes. And quite frankly, the thought that we would knowingly discharge patients with COVID into care homes, quite frankly, strikes me as being irresponsible. Thank you.
Okay, thank you, Councillor Whittington. So obviously, I'm very sorry to hear the news of your mother, and clearly it's very upsetting times for you. Can I just assure you, we don't discharge patients into care homes with COVID. We have what we describe as designated settings. So when I talked about designated settings, there are 2 care homes in Lincolnshire that the local authority have contracted with the The CQC have inspected and assessed as appropriate where we do discharge patients with COVID into those. That's at Avocet in Boston and Apple Trees in Grantham. We don't discharge patients that are COVID positive into care homes. But pathway 3, as I described it as a discharge pathway, is the discharge pathway into care homes. What we are doing is using our community hospitals to discharge COVID positive patients in, because again, we've got additional IPC training, we've got additional services that we can provide to those patients. So we're working very closely with the local authority and making sure that we do make the right decisions about discharge, and that we are only taking patients that are COVID positive into those designated settings or into our community hospitals. So I'd just like to give you absolute assurance that we have taken absolute rigorous testing to ensure that we are keeping patients safe. In relation to the issue that you raised around care workers and vaccinations, every year we have a flu vaccination programme that we offer to all care workers and healthcare staff. It is voluntary. We have not made those vaccination programmes mandatory. We absolutely would encourage all of our staff to have a vaccination. We absolutely see it as the way that we will protect both them and the public and the people that we're caring for. So we are offering those, but going through the priority groups. So it is the care home workers, frontline health and social care staff as our 2 priority kind of healthcare groups, and then rolling out, as I said, to the 4 priority groups as according to government policy. We can't make it mandatory. It is not within our, I suppose, our statutory areas to be able to mandate to staff that they have to have the vaccine, but we do all we can to encourage and make sure that people understand it's safe. We do regular bulletins out to our staff and update them on the safety of the vaccination programme, and also update them on a daily basis in terms of where they can have the vaccine and that kind of approach. So we do all we can to encourage, we do all we can to support our staff and ensure that they are able to get to those vaccinations and to provide that support and that protection. I think your first question was around, yes, the Grantham is a 24/7 walk-in, but within all of our services, such as urgent treatment centres, we always approach this as, if at all possible, please do use 111 first, because there may be other alternative services that we can offer you that would be more appropriate. We've talked on a number of occasions, I think, with the committee around virtual consultations, video consultations, and our ability to work very closely within those local community settings, which just does mean we wouldn't want people coming into UTCs unless that's the absolute right place for their treatment to be delivered. And again, that gives us an opportunity to have that conversation with the patient, look at what's available within their local area. We do a lot in our clinical assessment service through repeat prescriptions, and again, they don't need to come into a service to receive those. We can have that kind of prescription delivered to their local pharmacy as well.
Thank you, Tracy. I think that covers everything, Mark, for you, doesn't it?
As I say, the reason why I asked about health staff being vaccinated, because in Germany, key workers who don't take the vaccine are told to stay at home. They're not allowed then to have contact with, with patients. Spain are actually keeping a database of all those people who refuse the vaccine. I actually think on this, my personal view is any member of staff who refuses to take the vaccine should be sent home, because they're endangering, to me it falls foul of everything that they're supposed to be about. I'm just wondering if going forward we need to write into the contracts of employment of medical staff, and in fact all staff in the NHS, that they must ensure they do not potentially bring fatal diseases into hospital and care settings. For me, it's as fundamental as that, but obviously that's going to require government legislation. Thank you, Mr. Chairman.
Thank you, Councillor Whittington. Okay, thank you. Moving on, I'd like to bring in Councillor Kendrick, please.
Thank you, Chairman. Actually, my question sort of really comes in on the back of Councillor Whittington's as regards staff. All I wanted to know, and I apologise if I missed it in the papers, but I was just wondering what sort of percentage of staff of have actually received the vaccine? And also, what sort of percentage of staff are currently off work, either due to shielding or because they actually have COVID? Thank you, Chairman.
Thank you, Councillor Kendrick.
So in relation to staff that are currently off, we have in LCHS 19 staff off who are COVID or COVID-related self-isolating, and we monitor this on a daily basis and report those. The staff that are shielding are a different group, so these are staff themselves with health conditions that are shielding from home. They're still working. They are at home. We've got technology like we're doing today. They have their own technology at home. They're able to do some of the video consultations. They're able to do some of the other broader type of work from that home setting. So they're still working, but they're shielding from home. And again, at the moment, you know, whilst we are vaccinating that group of staff, they wouldn't return to the workplace because of the issues at the moment that we're not bringing even shielded staff back into the workplace even once they've been vaccinated. So I think there is something around those two groups of staff in terms of those two groups. So it's 19 staff off with COVID or COVID related for LCHS. Obviously, each organisation has a different number. And then our group that are shielding staff, whilst they are shielding, they are still working, but they're working from home.
And the percentage of LCH staff who have been vaccinated?
Oh yeah, the percentage, again, it changes on a daily basis, but we're about 60 to 70% of our staff that have received the first vaccination. So as you know, it is a 2-dose vaccination. When we're talking about numbers of staff vaccinated, what we're talking about is the staff that have received their first vaccination at this stage.
Thank you very much. Thank you, Chairman.
Thank you, Councillor Kendrick. I have 2 more speakers and I have some questions myself, and then I will be closing down the debate. So I now have Councillor Mrs. Harrison, please.
Thank you, Chairman. Morning, Tracy. In your presentation, you referred to using Louth Hospital for COVID patients. Could you elaborate on that, please, and explain whether or not it's having an impact on the usual services and the purpose that the beds at Louth are usually used for? Thank you.
So Louth Hospital, it is what we describe as our COVID positive ward. So the only patients that go over to Archer ward at the moment have COVID, so they are COVID positive. Obviously, they will complete their period of self-isolation, and those patients, the ones that when I was talking to Councillor Whittington around the patients that are COVID positive that either need a long-term placement or placement in a care home, what we are doing is bringing them into community hospitals first to support them through that kind of what we call that isolation recovery phase. If patients are diagnosed with COVID, they have to be isolated for 14 days. So it is that period of time of isolation and support. It does impact not on other services in terms of we still have other community hospital beds. So if a patient needs rehabilitation, so there are 4 pathways into our community hospitals. We have palliative and end-of-life care beds. We have what we call direct admissions from EMAS. So the EMAS see a patient at home and they want to bring them into a community hospital. We have step down, so that is where they were discharged from an acute into a community setting for rehabilitation. And then we have step up. So again, community nurses can admit straight into community hospitals. So those are kind of our 4 pathways. Primarily, when we look at those 4 pathways into our community hospitals, most of the patients that come into community hospitals actually step down from acute, so they're stepping out of an acute into a community for what we describe as rehabilitation. And as well as nursing and medical support within our community hospitals, we also have physiotherapists, occupational therapists, and it's that real rehabilitation that makes a difference to patients kind of going home with the right care and support around them. So we still provide that care, but we might have to provide it in a different hospital. So we still have Skegness and Gainsborough, as well as Weller Ward in Johnson. Or the other thing that we've really focused on, and in the paper it talks about the additional support that we're giving to take patients home with maybe additional support. So the discharge to assess model that we're talking about is where patients maybe before would have gone into community hospital, but actually what we see is that if we give additional support and care into their home, we can take them back home with additional OT, physiotherapy or nursing support.
Yeah. Okay, thank you. Thank you, Chairman.
Thank you, Councillor Harrison. I now have Councillor White, please.
I'd just like to make a comment about these designated places in care homes. I mean, are they sufficient? Because our experience of a 101-year-old resident who caught COVID in hospital was that he was sent home with minimum support. And when he eventually ended up in hospital, he ended up with 24 hours in A&E, and then he was sent round to John Coupland Hospital, who kept him for 1 day. And at the end of it, when we complained about it, we were told he should have been in one of these designated places. He eventually died. Thank you.
Tracy, I don't know if you can answer that if at all possible, please.
I mean, the designated beds, we have looked quite closely and done, you know, the two settings. What happens is the local authority leads on that commissioning of those designated settings. So it is a local authority lead working with the CCG. They did go out across Lincolnshire to ask providers to contract, and they procured those designated settings. They are, I think, in terms of is there enough? What we have actually found is in the designated setting, we've had low activity numbers, primarily as we talked about, because sometimes that patient needs an increased level of observation. The designated settings are residential, not nursing. And again, it was about what providers bid for those beds, not necessarily what we assessed as required across Lincolnshire. So we're just reviewing all of that. We constantly look at those designated settings, and we are looking all the time about, you know, have we got them in the right place? But if we do need to put additional beds in, well, apart from our community hospitals that we can use very flexibly and switch their use into those designated settings, actually the local authority would have to go out to procurement again. And I think that's quite a slow kind of process around that contracting procurement process. Very sorry to hear your experience and what you've just reported. And obviously, if there's additional work that we need to do to investigate that case, we were very happy to do that. It's not what we would want anyone to experience, and clearly isn't the way that we'd want patients to access or be cared for in our system.
I'd just like to ask, do the hospital staff, are they aware, the social workers in hospital, that there are these places that the county council have paid for?
Yeah. Yeah, so the social workers are the ones that assess the patient to go into the designated settings. So we use a trusted assessor role. So the care homes have identified trusted assessors. They do assess the patients, and they do assess whether they're appropriate to go into the designated settings. There's a lot of work, different teams working together, making sure that we are moving patients into the right setting. And I think that it's really challenging at times. Clearly, we don't want patients in hospital any longer than they need to be, because we know, again, there's a lot of, as you know, patients being cared for in hospital with COVID. So all the time we're trying to make sure that we're taking patients to home as much as possible, because actually that is where, you know, we would see patients, but if we can, that's where primarily patients say they want to be, and that's where we'd want them to be cared for.
Thank you.
Thank you, Councillor White. I have no further speakers, so I do have a number of questions myself, please, Tracy. My first question is, do you foresee the temporary opening hours at Louth and Skegness continuing beyond the 31st of March?
Okay. So, as you know, we asked for that extension, or we proposed that extension around the continuing COVID response. At the moment, as you know, we are still in surge, and we're still in the 2nd/3rd wave of COVID. So I can't identify whether we will be seeking a further extension or suggesting that we need to further extend that. And we will obviously have to review where we are in February and anticipate where we will be in terms of the numbers of patients that we're caring for in those different settings.
Okay, thank you. My second question is, on page 46, the 5th bullet point, it states that stakeholders will be involved in developing the future UTC and integrated urgent care offer. Yeah. Can you expand on who these stakeholders will be, please?
I mean, I think normally we talk about stakeholders, we talk about the range of stakeholders, you know, people that are part of NHS, the commissioners, the local population, yourselves as Health Scrutiny. You know, we have a kind of broad range of people that we talk about as stakeholders, and obviously Health Watch and those public groups as well.
Okay, thank you. That's reassuring. This is a rather long question, so try and bear with it. On page 51, the second paragraph, the report states that the overnight closure of of Skegness and Louth was determined not to have a noticeable impact on increasing patients attending Boston, North Lincs or Goole. However, my concern is that this was determined at a time when tourism to the area was practically non-existent compared to normal years. The report then states that the engagement exercise was based only on the temporary overnight closure and that full consultation will be made on any permanent changes, and the results of this engagement will help shape any future changes. My question is, how can this engagement, which took place during a pandemic, shape future provision?
Yeah, no, you're absolutely right. I think when we talk about taking engagement and helping shape, you know, we look over a range of years, and clearly, as you've identified, you know, last year, 2020, wasn't representative of what we would normally see in Skegness. We know that there was reduced numbers of activity in our UTCs across that period of time. So when we look at activity, we, as you can see in the report, we've still seen continued low numbers of public accessing our UTCs, and that's across the county, apart from the two co-located UTCs at Pilgrim and Lincoln. So when we start to look at this in a broader setting, we wouldn't just look at 1 year, we'd look at a range of years to see the impact from a postcode perspective, but also, you know, any consultation, any engagement would take a much fuller kind of number of information to shape that. It isn't just based on one piece of information or one engagement exercise, it's based on a range of different engagement exercises, and also trying to look at the future. So it's the future provision and the future kind of modelling that we can do about what do we think is going to happen in certain areas. We are looking, particularly at Skegness, at refurbishing. We're doing a capital scheme at the moment, so we want to upgrade the UTC at Skegness. We know it's the environment itself isn't particularly good to care for patients in. We've got 2 different waiting rooms. The consultation rooms are quite small, so we are working with a local kind of architect to do a whole capital build, and we want to invest in Skegness UTC. That is our future strategy as an organisation.
Okay, thank you. That's very helpful. My final question is on page 46, the 4th bullet point. The report mentions that LCHS will be undertaking an equality impact assessment. Is this something that you can share with the committee upon completion, please?
Absolutely.
Smashing. Thank you. Okay, in which case I would now like to move to a proposal. I propose to record the committee's support and thanks to all the staff at the Lincolnshire Community Health Services NHS Trust for their efforts in delivering NHS services in Lincolnshire. To note the report from the Lincolnshire Community Health Services NHS Trust on COVID-19 and the Louth and Skegness Urgent Treatment Centre engagement findings report. And finally, to receive a further update in April. Do I have a seconder for that, please?
May I, in seconding that, Chairman, ask through you, Tracy, if we could put in our motion that when there are changes to the numbers and locations of vaccination centres, we or Simon and Trina and yourself are informed, so we can be informed, because we can divert people who will get in touch with you when you are very busy. And I think what bothers me is with the distance people have got to travel, the sheer volume of vulnerable people who aren't going to have it done. So if we could ask that we be kept fully informed when there's a change and when local ones, I'll happily second it, Chairman.
I'm happy to take that on board. I don't plan on taking this to a vote, so we'll do it by dissent. If there is any dissent, please can you exercise this in the box now for speakers, please? No, in which case I'm going to take that as carried, and I would like to thank you, Tracy, for taking the time today. I know you're under considerable pressure, and so once again, thank you very much.
Very welcome. Thank you for inviting me.
No problem. Thank you. I'd now like to move on to agenda item 6, please. We have the Director of Public Health's annual report, which is at pages 63 to 84 of the agenda pack. And we have our presenter is Tony McGinty, Consultant in Public Health for Lincolnshire County Council. Once again, if I can ask for all questions to be at the end of the presentation, please, and to type speak in the chat. Hand over to you now, Tony, to run us through it. Thank you.
Thank you very much, Councillor Macy. Good morning, everybody. So the DPH annual report, as is mentioned in the covering paper, is an annual statutory duty of the Director of Public Health for each particular local authority in England. It's an independent report, so it's not a report from the council, it's a report from the DPH on an issue that he or she considers to be important in any given time period. As you would imagine, the last full year in question has been rather dominated by one public health issue, and we've been touching on that briefly a moment ago, talking about COVID-19 and its impact. So this current DPH annual report is almost a snapshot of almost a full year with of living with COVID-19 and the impact that it's having on local people. So my intention will be to pop some slides up, if I may, and take questions at the end. So I hope the technology bears with me. Okay. Do you now have a title slide?
We do, thank you.
Excellent, thank you very much. Glad that worked. Thank you very much for that. So it's an interesting time to be talking about the impact of COVID-19 in Lincolnshire, because of course, as we've heard from Tracy, we are not out of the woods with COVID-19 at all at the moment. And just to give you something of a feel for what's going on at the moment, we are still doing around 37,000 COVID-19 tests in one form or another in Lincolnshire every 7 days. In the last 7 days, we had 1,800 people in Lincolnshire test positive for COVID-19, and we saw an additional 46 people die as a result of infection with COVID-19 in that last 7-day period. Lincolnshire is performing reasonably well at the moment against an England average infection rate of about 470 per 100,000. Lincolnshire's average infection rate is 237 per 100,000, although there's a lot of volatility and variability in those numbers. I think it's really important to bear in mind, as I talk generally about the impact of COVID-19 on Lincolnshire, that the impact has been somewhat different in different parts of Lincolnshire at different points of the pandemic experience so far, and I suspect that will continue to be the case over the coming months. So I'm going to tell you a bit of a story of COVID-19 this morning. I'll go reasonably speedily and keep reasonably high level, and then focus on questions if that's okay with everyone. So first, a little bit about coronaviruses. Coronaviruses are a family of viruses that have been around with us for a very long time. Now they occur in lots of different species. Some of them occur in more than one species, and they certainly already cause human disease. So a lot of the seasonal sniffles, coughs, colds, tummy upsets that we get in the winter are caused by one or more of the family of coronaviruses. They're a virus which is quite adaptable, quite good at adapting to new opportunities, whether that's to jump from species to species or to adapt to become more problematic and cause more disease in the species that already has it. COVID-19 is the shorthand name for the coronavirus that we are dealing with at the moment. It's a virus of animal origin that has both jumped successfully into humans and gone on to prove itself to be capable of transmission between humans, hence the international pandemic that's ensued from that occurrence of the jump and then the ability to spread from human to human. So a lot of the year in question that we're talking about here has been all about control measures.
Is it possible to move on to the next slide? Sorry, I've just got some members asking because it's still on the first one at the moment.
Right, it's moving on my screen, but not on yours.
No.
Right, let me see what I can do about that. Has that moved it?
It hasn't as of yet, I'm afraid.
Aha.
The joys of modern technology.
That's rather annoying, isn't it? It's not moving when it's asked to. Let me stop and start sharing again to see whether that improves the situation. Has that made any difference?
It hasn't, I'm afraid. It's still on the landing page.
Right. I don't quite know what to do about that, why it isn't moving, well, not as I'm moving. Do members have a copy of the annual report in their pack?
Yes.
We do.
Could I ask then that you flip to those, because the main content of the rest of the presentation is graphs and figures from that report.
That's absolutely fine. Thank you, Tony. I know you've tried your best with that. So thank
sorry,
you. I'll let you carry on, in which
no,
case.
No idea why it's not working. So, yes, as I say, the control measures that we've been using in this first year were largely, especially in the early stages, about human effort to keep away from each other and to avoid transmission of the virus, whilst we gradually learned what the virus was capable of. We learned how to test for it, and we learned more about how to keep people safe from it when they did become ill, with improvements in treatment. And obviously we launched a great deal of vaccine research at around the same time, which we're now seeing the fruits born from. So if I can ask members to turn to, there's a line graph in the document entitled "Daily Number of Cases" on the left-hand key side.
I think it's page 69, Tony.
Thank you very much. I'm not clever enough to do this and look at the document, Trina. Okay, so you should be able to see a fairly simple looking line graph with a blue jagged line, and the left hand key says daily number of cases. The bottom key says specimen date with a number of months from 2020 along it. This is an indicator of the numbers of cases we have seen of COVID-19 in Lincolnshire people over that lifespan of the virus up to the end of November last year. We pulled it at the end of November because that was around the time we were finishing this annual report. I think it's fair to say that the daily number of cases that you see at the peak in November has been sustained more or less now for a significant period of time, and up to the point where the government put us all back into a national lockdown shortly after Christmas to try and bring that under control. Moving on in terms of current impact, there's a further line diagram entitled "Daily Number of Patients," again with the date line of months in 2020 across the bottom there.
Page 71.
Thank you very much. And that gives you an indication. If you overlay the previous graph with this graph, what we see very clearly is a close tracking some 7 to 10 days after case numbers increase. We see daily number of patients admitted to hospital increase as the relatively small but important proportion of people who become seriously ill from COVID require a secondary care level of healthcare intervention. So you can see that, and again, the issue of the peak at the end of November continues again for us over the coming months. And I think Tracy's touched a few times on how much pressure there is in the healthcare system in the UK and in Lincolnshire at the moment because of the impact of COVID-19. That is continuing and will continue generally with that same time lag after the point at which case rates start to come down in the community as a whole. Slightly further on in the report again, then there's another graph. Again, we're focusing on current impacts, which is two simple lines, a blue line and a brown line. with week numbers across the bottom. This graph shows us deaths related to COVID-19 in the Lincolnshire population. This is a cumulative total of deaths. The reason why there are two lines on there is because we've got two different counts running at a national level of COVID-related deaths in the UK. The numbers, as you can see, are fairly close to each other, and that's further complicated by the fact the government changed the definition of COVID-related deaths partway through the year that we're reporting on at the moment. But again, you will see a really gentle time lag from case rates going up to hospital admission rates going up, and then mortality rates following behind that, as some of the people who get seriously ill unfortunately don't survive their experience with COVID-19. So moving on to the way forward, then the best estimates for most public health professionals now that we will still be taking precautions at a population level for COVID-19 well into this year and into the autumn. So some of the measures around social distancing, the use of protective equipment, infection prevention control measures, continuing to test the population, trace cases, ask people to isolate, etc. will continue. Treatment improvement will continue, and vaccine deployment will continue. The reason why I'm being slightly pessimistic there and what I think is likely to happen next is because we are still learning what this virus does and doesn't do. We're still learning about the length of immunity that vaccines will provide over time, and how much immunity is afforded by people who've been infected over time as well. So it's quite hard to get to the point of feeling comfortable about how we manage life with COVID-19 going forward until we've lived with a vaccine deployment for some period of time and understood properly what kind of immunity is inferred by it, or by it either by vaccine or by becoming infected by it. The final slide I'm using is again in the report. It is a multicolored line diagram this time, burden of disease being the left hand side and time being the bottom axis of this particular graph. My reason for identifying this with you is that it's pretty clear from a public health, both excess mortality and health impact point of view, that COVID-19 will continue to have significant impact on the health of the people of Lincolnshire for some significant time to come. There's a range of reasons for that. One of them is that COVID won't entirely go away now, we think, for some significant period of time. We know that there is a backlog of both routine and less routine healthcare interventions as a result of either COVID restrictions on service deployment or on people behaving differently around their health, not seeking as much early help and advice as we would have wanted them to, and therefore having poorer long-term outcomes from health conditions which have been brewing during our time with COVID that they haven't managed to address so far. So I think what may become the subject of future Director of Public Health annual reports for Lincolnshire and other parts of the country is this kind of surveillance of what impact COVID-19 will continue to have on the population as we go forward. I shall stop there. Thank you very much. I'm sorry for the technology failure.
Oh, that's okay. We all suffer that at the best of times at the moment. I'll hand over to Councillor Brewis for the first question, please.
Once again, I think it behoves me to thank Tony very much. And the annual reports have always been very readable and very relevant. And I think I thank you for what I think is a very clear, and which bears out my belief that we will be with this 9 months of the years to come. and I don't see our current crisis easing off until well into 2022, but I could be wrong. And I note too that the government at the moment, I don't know what your reaction is, or the national figures, suggest that due to testing, they think as many as 7 million people may have had it, of which the majority will have been asymptomatic. How we balance all this and whether they've now got immunity, how on earth are we going to balance all these very difficult sums? And you may have heard what I said earlier to Tracy. How are we going to ensure that the people who do not want to, if I take Princess Royal Sports at Boston, a journey from my end to there is 2.5 hours each way, and vulnerable people are not prepared to entrust themselves to public transport for 5 hours. So how soon does Tony think we're going to get it locally in some of our health centres, in, for example, Crowland and I know Crowland and Bourne and Long Sutton and so on, because I think this is the only way we're going to tackle and get people who want to be vaccinated able to be vaccinated because of the aversion to a very, very long journey through potentially dangerous countryside.
Thanks, Councillor Bruce. Obviously, the rollout and uptake level of the vaccines is incredibly important now in terms of speeding up our return to some degree of normality in terms of having this particular virus in its place as a threat to human health. I won't steal the NHS's thunder by describing the Herculean task that they have in trying to get as much vaccine as close to as many people as they possibly can at the moment. The government plan is really ambitious. I think it's very ambitious for a county like Lincolnshire with our geography, our age profile, the numbers of care settings that we have, etc., etc. So my NHS colleagues have particular challenges, I think, about getting this vaccine programme up and running in Lincolnshire. This vaccine programme is going to be with us for a long time. The main threat that the vaccine is trying to offset at the moment is the tendency for certain parts of the population to get really sick, to then become unable to manage day-to-day life and become become massively dependent on the health and social care system. And my belief is that that's the right policy. We have to protect the rest of the health and social care system first by defending those most vulnerable people, and then move on to having the right vaccination programme to put this virus in its place going forward. Exactly when that will be, I don't know, but clearly the government's fairly ambitious about having the majority of adults immunised from COVID-19 before we go into next winter.
Right,
sorry,
mute, Chris.
Thank you. And I think the other point I'd make is when a lot of people earlier in the year were discharged into old people's homes, several people have said to me they thought it was deliberate policy to get off pensioners and save the money. And I'm not sure whether that's true, but it seemed to me to discharge people into old people's homes, which by their nature, social distancing is impossible, was as irresponsible as you possibly could be. But I don't know, maybe I'm wrong.
I'm happy to say in Lincolnshire, social care and health worked really hard in wave one to not discharge people directly out of hospital with unknown COVID-19 statuses. So even though the approach to that was patchy across the country, Lincolnshire's approach was probably more robust than most, and we did have a relatively low infection rate in care homes and a relatively low more excess mortality rate in care homes in the early stages of COVID-19 as a result.
Thank you very much.
Thank you, Tony. I've now got Councillor White, please.
Thank you. I'd just like to ask a question. I probably should have asked it from the previous speaker about care homes. are any GPs going into care homes, or is all the diagnosis going on by video link? I mean, I feel very sympathetic to care home staff. Most of them aren't medically qualified. From my experience as a first responder, they have no oxygen. They're not trained to administer oxygen. So if it seems to me that we've made our residents of care homes more vulnerable than what they should be.
It's a hard one to call this. As part of the preparation for the onslaught of the epidemic early on in the year, we deployed a lot of additional support and technology to care homes, including, designating primary care practices to care homes with kind of responsibility for oversight of what they were going on. I'll be fundamentally honest with you, Councillor White. My experience of supporting care homes from a public health point of view during the year or so in question is that different clinical teams have been able to respond slightly differently to care homes depending on what position they were in. Over time, I've seen some really absolutely cracking examples of primary care teams and LCHS services and other frontline services being in really rapidly with care homes. I've seen other experiences where they found that more difficult and they've been more remotely managing the health impact for residents of care homes rather than being in the care homes. The general advice throughout for care homes has been not to let anyone in unless they really had to let them in. And I think that reliance on technology has been part of the product of that advice to try and if you like, build barriers around care homes and keep them try and keep the infection out entirely.
Thank you. Okay, in which case we'll move on to Councillor Whittington, please.
Thanks, Mr. Chairman. I won't risk the camera again. My first question, Tony, is around the vaccine and the nature of the vaccine that's there. I mean, and a couple of questions. Do we think that this vaccine is going to be like the MMR vaccine, and you get inoculated once and for life protection, or is it going to be more like the flu vaccine, where it needs to be done every year? Because if it is, and the entire population needs to be vaccinated every year, it's going to be a tremendous. I mean, we're virtually going to have almost permanent vaccination teams. Or would it be possible? I don't know if it's possible. I know, with the MMR vaccine, there's several vaccines together that are admitted in one dose. Would it be possible going forward maybe to build the COVID vaccine into the flu vaccine, for instance? Because I'm also wondering about the efficacy of some of the clinical trials, because as you obviously know, Israel are quite a way ahead in terms of inoculating their population, and I believe they're using the Pfizer vaccine. As reported today in the newspaper, that certainly the reports coming out of Israel is that they don't think the first dose is as effective as the clinical trials would have indicated. So that would be my first question around the vaccine itself. My second question relates to the 28-day period that obviously only patients who've had COVID within 28 days are classed in the death figures, because we obviously know that there is the impacts of long COVID. And again, I read in the papers this week that it's reported that over a third of patients who were previously in hospital with COVID were subsequently readmitted. And of those third, a significant proportion then subsequently died. Now, obviously, COVID-19 probably won't be recorded on their death certificate. And obviously, you probably heard me speak about my mum, who was tested positive for COVID in November, but died on the 11th of January from a subsequent chest and water infection. So the cause of her death was listed as bronchial pneumonia, which is the effect of the chest infections. Now, she also suffered from type 2 diabetes, and that was listed as a secondary cause. But my argument should be that for those patients potentially who are long COVID, maybe COVID should be on them, if not as a primary cause of death, then it's almost as a secondary cause. So I'm just wondering why the government picked on this 28-day period, because we know the nature of diseases. That some people, they do have underlying conditions, whether it's COPD or diabetes or whatever. It may not be when those patients finally die their actual cause of death, but it's always listed as a secondary cause. Because I'm just thinking to myself, this number of 90,000 deaths that sadly have been reported, I think could be grossly underestimated if we build in the impacts of long COVID. And going forward, how could the medical and scientific professions identify what was the true casualty rate of this pandemic? Thanks.
Thank you, Councillor Wilson. So I'll start with a bit of a thought about the vaccines. I don't think the vaccines that we're deploying today will be the same product as the vaccines that we deploy into the future, if indeed we decide we do need to continue to deploy vaccine for this particular coronavirus. So I think you hit on a really important point that the vaccine program that we're rolling out today probably won't be the vaccine program that we end up with around COVID-19. I think the without getting into too much technicality, the reason different vaccines last for longer or shorter than each other is largely to do with the way the organisms interact with the vaccine and with the host. If you take flu, for example, we have to change the flu vaccine really frequently because the flu vaccine adapts and changes very quickly year to year. So we assess each year whether we've got the right viruses targeted. COVID viruses, somewhere in the middle of that spectrum, they tend not to mutate as rapidly or as significantly as the flu family of viruses, which might suggest that the vaccines we have now will have more longevity of use than maybe flu vaccines do. If you look at something like MMR, though, measles, mumps, rubella don't change very much over quite long periods of time. So the vaccine tends to have long-lasting effect, and the way the vaccine motivates the immune system gives longer-lasting immunity as well than some of the vaccines that are designed to provoke short-term immune response to diseases. So all in all, it's a really complicated picture. I wouldn't be surprised if for a few years at least, we have a program of vaccination for COVID-19 for at least some of the population, if not for all of us, given how badly we know it impacts on people with particular vulnerabilities. Particularly, so I hope that goes some way towards explaining that. I think the vaccine profile that we're dealing with now is very fluid and will be quite different as we progress forward. And as you say, we don't actually know at the moment how long the vaccines provide immunity, whether they are going to provide immunity against serious disease or against catching COVID-19 at all, because those two things are not entirely the same for these vaccines either. In terms of the death count and the change in the way that the government counted mortality, the UK government was out of step with the World Health Organization's advice on how to count COVID mortality, and that was the main reason given for the change to counting deaths within 28 days of diagnosis back in the early part of last year. What I would say though is you can rest assured that the public health system and the NHS are doing a great deal of analysis on excess deaths in total resulting from COVID, whether that's long COVID, the COVID having damaged someone's respiratory system and therefore shortened their life if they suffer from respiratory problems in general terms. So there will be both the short-term measurement of directly attributable deaths within 28 days and the longer-term excess mortality caused by COVID for one reason or another going forward. So we should end up with quite a full picture, I think, of the impact, fuller than we have currently. Councillor Whittington.
Okay, thank you, Councillor Whittington. Thank you, Councillor Renshaw. I'll have you next, please.
Thank you, Chairman. The last line in the report is where I would like to start. The hands, face and space. It's something that I've spoken long and hard about on many occasions, and but I'm so important that it does need to be said again. This is the government's message, but in reality, compliance comes and goes in waves, depending upon the current national perceived severity of COVID. For instance, it's on live television daily in the adverts, but the government probably doesn't recognise that not everybody watches live television. There's massive amounts of the population just have the telephone for the social media aspect, and maybe on their entertainment side they probably go on Amazon Prime or Netflix. So it's getting the message out for people to be compliant. The local reality, and that's where I raised the question at the last council, that and it's still prevalent today, and that's the important thing and why I repeat it today. That 2 meters to a significant number of the population is 2 inches, particularly to people like the runners who are going for exercise, and I welcome them taking the exercise, but they think that the way to get from A to B is a straight line, and irrespective of the elderly population trying to get the daily exercise, we're not going to move for them, you know. So there's a matter of the population's got to live up to normal lifestyles and be respectful of each other. This, as Tony's just said, this is not going to go away, and it's going to be a long time with us. So what I'm saying is entirely more and more relevant. And as I said when I spoke to Tracy Pilcher early on, the reality of what is happening must not be kept from the public. If the public ignore the rules, it's going to take longer to get out of this crisis and regain some normality. And everybody, I think, really wants to get back to normality as soon as possible. But it's what comes first, and what comes first is hands, face and space. Thank you, Chairman.
Thank you, Councillor Renshaw.
Thank you for that. Interesting for me, one of the impacts I've been monitoring from the COVID-19 period is the effect on the incidence of other communicable diseases in our population, because clearly there are a number of other communicable diseases that are supported, prevented by people mixing with less people, staying further apart from people, washing their hands more often, catching their coughs and sneezes in whatever way they can. So I'm with you where I think the public health system and the national government will be encouraging the population to maintain the gains in other diseases as well as COVID-19 that they've achieved by the majority of us complying most of the time with the rules that we've been asked to follow.
If I may just come back, Chairman.
You may, yeah.
That's very good, and it is up for national figures to show a better example. The government's allowed football, for instance, to come back, and it's on the screens, and there's a big cohort of people watch it daily, and it's so sad, isn't it, to see them totally ignoring the hands, face and space, and dare I say it, spitting when the camera's on them. You just cannot, I mean, those habits when you're on live television are unforgivable, and it's so sad that the message not got across, and the government can be really nasty with them and say, right, we're going to ban all football, but allowing some freedom like that shouldn't be taken as a free for all. And I didn't forget to say on the page 83 above there, Tony, you did refer to the mental health support, and it's not least of all that the mental health support to staff that's working in the NHS, because of the intolerable burden they've faced for the last 12 months, it has got to be primary, one of our important things to make sure that they are covered by mental health support. It's very important for them. Thank you.
Quite right. I've bored myself on the radio and other places saying that the rules are the limits of what we should be doing, not a target to aim for. And I think that's got lost in translation occasionally, hasn't it?
Thank you, Councillor Renshaw. I have 3 more speakers and then I'll plan on closing down the debate. I have Dr. Wookey first, please.
Thank you, Chairman. First, I think probably our organisation and all of us would thank the Department of Public Health, who have clearly worked very, very hard throughout this period of the last 12 months of the pandemic, and perhaps not always, we perhaps don't remember to thank Public Health for all their work, and the fact that I think it's increasingly clear that it is local public health which is being effective in our improvements rather than necessarily national. So thank you, Tony, to you and your colleagues. I think that's very important. Going on to the report, in fact, it leads on from that. On page 72, 73 and 75, there are some graphs which show very clearly and really almost quite alarmingly how the incidence locally of a number of issues rose in September. This was community workplace outbreaks, care home outbreaks, and on the following page there's another one, all of which shot up in September, not in November or October, November, December, as we might have expected. And I think that again shows that actually the early warning signs that you were getting in September, when nobody was really thinking of locking down, are an example to all of us really, and for planning in the future, because it's clearly that the lockdowns came too late on each occasion. I'm not apportioning blame, but I think we should take that as a guide for the future, because we may well have further humps and bumps along the way. So I think those are very important, those graphs. Also, there is no mention at all of Northeast and North links, and I assume you must be working closely with them, but I couldn't find any reference to that in the report. And for example, if you follow the statistics for East Lindsey and Northeast Lincolnshire over the last 3 months, they follow each other very, very closely, almost as though the same guy had done the graphs. They went up together and they went down together. So I assume that you are working very closely across the borders on that. And I'd just like a little bit of comment, please, regarding that. And just lastly, I agree with everything Councillor Renshaw has just said, and that you and the replies that you made to him. Thanks.
Thank you very much. Yes, I think the public health system in the UK will learn a great deal about localism as part of this epidemic response, both in terms of our ability to see things coming, which take national organisations a little while to see as equally important, and I think we'll learn a lot. I'm guessing the committee might take some interest in the transformation of some of the national public health bodies into the new national body that's been announced by government some time ago, and how that will adapt to the lessons learned, I suppose, from the public health system in the UK from this. In terms of working relationships, I think I can honestly say I've never worked as closely with public health colleagues in surrounding authorities as I have in the last year or so, running common incident control team meetings, having really frequent meetings with lead public health staff from those authorities when we're seeing numbers in a particular area accelerate and we don't understand why. And I now have familiarity between about how mobile our population is, the edges of the county in and out of other surrounding areas. So we've been very heavily involved with other authorities, including North and North East Lincolnshire, sharing information with each other about outbreaks where some of the people are resident in their area but are working in our area, for example, in a care home or a school. So lots and lots of really detailed cooperation. I think it's fair to say.
Thank you.
Okay, thank you. Can I have Councillor Woodliff, please?
I was interested in Tony's earlier remarks about sort of other effects of the coronavirus crisis. And one thing that's crossed my mind from time to time is we've never ever before had mass use of, for example, sanitizer throughout the country. And I was just wondering, when you do your study, whether that might throw up, for example, a reduction in the number of infections that you get from, you know, such as stomach complaints and gastric problems because of the increased use of sanitizer. I'm just wondering, that's an unintended beneficial consequence, shall we say, of the campaign to combat COVID. I don't know if Tony's got any thoughts on that. Thank you, Chairman.
Absolutely. I can definitely see in the notifications of other outbreaks of other types of illnesses in Lincolnshire and in the national notification of notifiable diseases that the picture has been different than it usually is whilst we've been dealing with COVID. I'm being slightly cautious about whether that is to do with a component of the COVID response or to do with the negative effect of people not reporting other things, because we've seen some of that too. Councillor Kendrick, I'm pretty confident though that at least a portion of the improvement we've seen in other infectious diseases is to do with the increases in hand washing, use of hand sanitizer, and people just generally being more aware of personal hygiene, social hygiene.
Thank you very much. Thank you, Chairman.
Thank you. The final speaker I have now is Councillor Woodliff, please.
Thank you, Chairman. Can you hear me?
We can hear you.
Right, okay, I'll leave it on that. I'm not going to put the video on. That might be a problem. Good morning, Mr. McGinty. Do you know how many mutations of C19 there are in the UK?
I know about the major ones. There have been more than a dozen slight mutations identified. At the current, we are tracking variants which have got significant differences. We've seen in the news more emerge from time to time.
Sorry, I didn't pick that up.
So I think if we talk about significant variants, so where there is a significant genetic difference between the viruses, at the moment there are 4 main variants in the UK that we are aware of. There are likely to be others which are not significant enough for us to have noticed them at this point, and more emerge from time to time.
So how many is that? How many do we have in the UK?
So at the moment there are 4 major variants or significant variants that we have line of sight on in the UK. There's so 4 significant ones.
And do we believe that the vaccines are able to cope with these?
So my understanding of the way the science is keeping pace is 3 of those we have tested sufficiently to satisfy scientists that they are not going to be vaccine dodgers, to use a vernacular term, if I may. And each variant that arises is quite rapidly tested for review about whether it's sufficiently different to existing variants and the variants that the vaccines were built upon to enable them to dodge vaccine. We haven't had one of those yet.
Right. Do you think that does it appear that men are more likely to die of this virus than women in this country? I mean, is there any evidence to support that? There is an assertion that men are more vulnerable to this. Is that true?
Looking back over the data so far, the mortality rate is slightly higher in men than it is in women. However, it's hard to determine whether that's a direct COVID effect or the fact that premature mortality particularly, is higher in men in the UK anyway. So it's hard to tell whether that's a direct COVID effect or just that more men have those underlying conditions which make them vulnerable.
Yes, because this is primarily an attack on the lungs, isn't it? This particular virus latches onto, I think, is it enzymes in the lungs and destroys them? Is that fair to say?
That's right. Well, for people who become very poorly, it does attack the functioning surface layer of the person's lungs, rendering it very difficult to get oxygen transport from lung to bloodstream.
Yes. All right. So I suppose the other thing I have in mind is that we know that this virus came from China, and there have been various suggestions from the Chinese about where it came from a meat market, from a mine, and I suppose in the United States. There's a view it came from the Wuhan germ warfare establishment, which is 10 miles outside of Wuhan. There's all sorts of options on that. What's the general thinking on that at the present minute?
The general opinion of the virologists and geneticists is this is a virus that jumped from another species. That leads you to the conclusion that it's made that jump repeatedly before it was capable of managing human-to-human transmission. So it looks like it's animal origin rather than manufactured. It's a close relationship with a number of naturally occurring coronaviruses in other species. So yeah, the weight of evidence suggests it isn't manufactured. It's a virus that has naturally managed to make the jump into the human species and then adapt sufficiently to be transmitted from human to human. The epicenter of the international pandemic was that province in China, which suggests that whatever the originator of it was, it originated somewhere in that region.
Because we know that when all right, okay, I'll leave it at that, Chairman. Thank you very much indeed for allowing me to speak.
That's fine. Thank you, Councillor Woodliff. I have no further speakers, so I'm going to move to the proposals. I would like to propose that we receive the annual reports by the Director of Public Health, to thank those working in public health for their work during this pandemic, and to note the updated information on the COVID-19 pandemic. I would also like to wish Tony all the very best for the future, as I understand he will be leaving LCC at the end of the month, and thank him for his involvement and support with this committee for many years now. So thank you, Tony. Do I have a seconder to that proposal, please?
May I second that and particularly endorse your last couple of sentences, how to keep us well informed, concisely and effectively. And I thank you, Chairman. So I'll second.
Thank you. In which case, I don't plan on taking it to the vote, but if there is any dissent, can you please type in the chat box now? Okay, no, in which case that is carried. Thank you. I'd like to thank you once again, Tony, and wish you all the best once again. Thank you.
Thank you. Thanks for those kind words. Thank you, everyone. Bye-bye now.
Bye. In which case, we'll now move on to agenda item 7, United Lincolnshire Hospitals NHS Trust, outpatient services at community hospitals. Simon, I'll hand over to you just to run us through this, please.
Yes, thank you, Chairman. This item raises the issue of outpatient services at community hospitals. There were some concerns raised just before Christmas, where some local councils has heard that United Lincolnshire Hospitals was planning to discontinue outpatient services at certain community hospitals. So this item addresses this. A letter has been received from the Chief Executive, Andrew Morgan, which is set out on the additional information that was circulated on email yesterday. And essentially, this is saying that this particular activity or consultation with staff or engagement with staff has been suspended because of the COVID-19 activity. So at this stage, they are not taking anything any further, but they will be, I assume, revisiting this later in the year. Thank you, Chairman.
Thank you, Simon. Yeah, as Simon says, I've heard of it, certainly in Skegness myself. I know other colleagues across the county have also heard this issue. So what I plan on doing is making a proposal that we note the response of the Chief Executive of United Lincolnshire Hospitals Trust on the outpatient services at community hospitals, which includes statements to the effect that, owing to COVID-19, discussions with staff on any changes have been suspended, that there is no agreed timetable for discussions with the Clinical Commissioning Group or LCHS, and consultation and engagement will take place before any substantial changes or developments take place in the provision of services at community hospitals. I'd also like to put on record the committee's view that all the county's community hospitals provide a valued contribution to the delivery of NHS services across Lincolnshire, and to add an item to the work programme specifically to cover any future developments at the Lincolnshire community hospitals. I have a seconder for that proposal, please.
I'm happy to second that, Chairman. I think the other thing we have to bear in mind too is that if the current crisis carries on for, let's be generous and say, a year and a half, 2 years, then we would want some interim arrangements to happen, and we need to be kept informed. But I'll happily second your motion, Chairman, and I think we just need to be kept informed regularly to ensure that nobody loses sight of what you're saying. Thank you.
Thank you, Councillor Brewis. In which case, I propose not to take a vote, but do it by dissent. Is there any dissent? If you could please let us know in the chat box now. No, in which case I would take that as carried, and we will move on to the next agenda item, which is agenda item 8, urgent and emergency care, models of care and measurement. Simon, if I can hand over to you, this can be found on pages 87 to 94 of the agenda pack. A further draft response has been circulated, which has taken on board the comments received from colleagues. Simon.
Yes, thank you, Chairman. Back in December, NHS England NHS Improvement launched a consultation effectively on the performance measures for urgent and emergency care, and that consultation document has been circulated to the committee with a set of draft questions. As the Chairman has just said, on the basis of the comments received, a further draft has been circulated, and that is for the committee's consideration today as its response to the consultation. Thank you, Chairman.
Thank you, Simon. Councillor Brewer, if you'd like to come in, please.
Yeah. I think mine, if we live in the extremities of the county, in the north or the west or the south, an awful lot of people go. I remember once the East Midlands Council was referring to people who went for any purpose into East Anglia or the or other areas of the Midlands as leakage across the border. But at least I'm very grateful to Simon for confirming that patient choice still applies, so that people in Crowland can go to Peterborough and people in the Far East can go to Lynn, and people up in the north can go to Doncaster or wherever is most convenient for them. I think what we need for everybody's health and safety is joined up thinking. But the one point I would raise is that the fact that we can't get the variety of things available in community hospitals, if that gets reduced and so on, there's a real problem there with more things going out of county and more funds going out of county, thereby preventing the services running effectively within county. It's a very complex matter. Thanks, Jim.
Thank you, Councillor Brewis. Councillor Kendrick, you'd like to come in, please.
Yes, thank you, Chairman. Yeah, I mean, I think this, and particularly looking at the response that is being drafted, I think it's interesting. Again, this is something which is a hangover of the sort of target culture we had some years ago in every aspect of public service, and a more nuanced approach, which seems to be quite sensible in terms of the way A&E, for example, the different factors are taken into account rather than just a basic 4-hour rule. I think hopefully that might throw up some more useful data which can be used rather than a rather basic system that was in place before. So yeah, I'm in favour of the response that has been drafted. Thank you, Chairman.
Thank you, Councillor Kendrick. Yes, I certainly concur with all of that. I think it's a more positive way to measure moving forwards. In which case I have no further speakers, so I will make a proposal that the draft response as circulated be approved as the committee's response to the consultation on emergency and urgent care models of care and measurement. Do I have a seconder for that, please? Thank you, Councillor Lewis. Thank you. In which case, once again, I plan on taking this by dissent. If there is any dissent, please type in the chat box. If not, I will take this as carried. Okay, in which case that's carried, thank you. We'll move on to our final item, which is item 9, the work programme. So Simon, if I can hand over to you to introduce the report that is found on pages 95 to 102.
Yes, thank you, Chairman. If I could ask the committee just to look on pages 96 to 97, where we have the items for the February and March meetings. During the course of the morning, we have added an update for the April meeting, which would be on the 21st of April from LCHS, and we're also in the longer term going to be returning to provision of outpatients at community hospitals. I also understand that there is a request for consideration of a report that's being undertaken currently or being prepared currently by the Care Quality Commission on Do Not Resuscitate, which has been an issue which the CQC has been focusing on from the beginning of the pandemic. So those 3 things are added to the list. Thank you, Chairman.
Thank you, Simon. Yes, certainly. Councillor Harrison, obviously you raised with us that you would like to see on the work programme moving forwards the do not attempt cardiopulmonary resuscitation paper, and that will now be added as requested.
Thank you, Chairman.
No problem, thank you. Is there anything further from any members?
Chairman, may I?
Yes, certainly, Councillor Harrison.
Please. We have, I'm sorry, I'm always about this one, but we have in March pain management service. A while ago, I did raise about the potential of investigating the use of opioids, and that is one of the things that the pain management service is supposed to be reducing the use of. So could we possibly put that in the request for the information that we require?
We have already done so, so we'll make sure it's there.
That they're meant to be produced, you know, their service producing. Thank you.
Yeah, as I say, it is something we've already requested from them, but we'll ensure that it is part of it when we bring it to the committee. Okay, any further comments, please? Cowley, did I just see you raise?
Yes, Councillor Massey. In relation to the opioids, just bear in mind that most of the opioids are used in primary care. So if you want an update on opioids use, you might want to include not just the pain management service, which is doing quite a good job now in reducing opioid use, and also include the primary care.
Thank you. I think that's very useful, and we'll make sure that we do try and get that included as well moving forward. So thank you for that. Okay, in which case I have no further speakers. So I propose that the work programme will be noted. We'll have a seconder, please. Thank you, Councillor Brewis. In which case, once again, I propose to take it by dissent. Is there any dissent, please? No? Okay, well, in which case that is taken. Thank you. And that brings a close to the meeting. So I'd like to thank you all for your attendance and taking part today. And I look forward to seeing you all again. So take care and keep safe. Thank you all very much.
Take care.
Take care.
Bye.
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 Bye, Chairman. Thank you. Bye, colleagues.
Well done, Chair. Thank you very much. Bye.